More and more people are being told they have ADHD, and for many, that's life-changing help. But some experts now argue we've swung too far, and that ADHD is being labeled, medicated, and debated in ways that were unthinkable a few decades ago. The big surge in ADHD labels. In several high-income countries, ADHD diagnoses have climbed dramatically, especially over the past 20 to 30 years, with both children and adults being identified in record numbers. In the United States, for example, government data suggests that well over 1 in 10 children has been told at some point that they have ADHD, compared with noticeably lower rates in the early 2000s. What makes this especially striking is that when researchers carefully measure symptoms such as inattention, impulsivity, and hyperactivity in representative groups of people, the underlying proportion of individuals who meet strict ADHD criteria appears far more stable worldwide. Large global analyses estimate that only a small fraction of children and an even smaller fraction of adults meet those rigorous research definitions at any given time. Overdiagnosis, or finally paying attention? Here's where it gets controversial. Health officials and commentators in some countries now describe ADHD as part of a broader overdiagnosis and overtreatment crisis. They question whether medications really help over the long term and worry that some people are being labeled on the basis of quick visits, online questionnaires, or non-specialist opinions. At the same time, many clinicians and advocates insist that the bigger problem is the opposite. People who clearly struggle with ADHD symptoms remain undiagnosed, unsupported, and at higher risk of school failure, injuries, and substance misuse. They argue that when ADHD is recognized and managed properly, including with medication when needed, it can dramatically improve functioning and quality of life. Neurodiversity versus disorder. One bold, emotionally charged tension sits at the heart of the current debate. Is ADHD a disorder to be fixed, or a difference to be understood and accommodated? The neurodiversity movement challenges the idea that ADHD is simply a defect in the brain, and instead frames it as a natural variation in how minds work. From this perspective, environments such as traditional classrooms or rigid workplaces are disordered because they were designed around a narrow idea of how people should concentrate, sit still, and learn. Supporters call for adapting schools and jobs to better fit different attention profiles, for example, allowing more movement, shorter tasks, clearer structure, or alternative ways to demonstrate learning. The case for ADHD as a medical condition. On the other hand, many people with ADHD and many specialists are adamant that it's not just a quirky learning style or a personality type. They point to very real challenges: difficulty keeping up academically, getting fired or underperforming at work, more accidents or injuries, higher rates of anxiety, depression, and substance problems, and strain on relationships. Medication, in this medical model, is not about normalizing someone's personality but about reducing symptoms enough that the person can make use of their strengths. For a lot of individuals, especially when combined with behavioral strategies, coaching, and environmental changes, treatment can mean the difference between chronic crisis and a manageable, fulfilling life. Gift, superpower, and serious struggle. Another emotionally loaded theme is the idea that ADHD is a gift or superpower. Some people with ADHD say their fast-moving minds, creativity, and willingness to take risks have helped them excel in entrepreneurship, the arts, or problem-solving roles. It can be powerful and healing for someone to reframe their traits in a positive light after years of criticism. But here's the part most people miss: celebrating strengths should not erase the very real distress ADHD can cause when it's undiagnosed or poorly managed. Someone can be both highly creative and chronically overwhelmed, both energetic and exhausted by constant chaos. Both the gift narrative and the disorder narrative capture part of the truth, and neither tells the whole story on its own. Why diagnostic numbers don't match true prevalence. If careful studies suggest that only a small percentage of children and adults fully meet ADHD criteria, why do some surveys show much higher diagnosis rates? One reason is how the questions are asked. Large national surveys often rely on parents or adults recalling whether a health professional has ever told them they have ADHD, which can easily inflate the numbers. People may misremember a description of ADHD-like symptoms as a formal diagnosis. Children whose symptoms improved may still be counted as having ADHD, and some individuals may have been labeled by practitioners without specialist training. These kinds of methods are useful for spotting trends but are blunt tools for determining how common ADHD truly is. How the rulebook has changed. ADHD diagnoses don't exist in a vacuum. they depend on diagnostic manuals that evolve over time. Earlier versions of the main psychiatric handbook required a relatively high number of symptoms, and those symptoms had to show up before around age 7. Adult diagnosis also tended to mirror child criteria quite strictly. Newer versions relaxed some of these rules. The age by which symptoms must appear was increased, and the number of symptoms required for adults was reduced. It also became more accepted to diagnose ADHD alongside other conditions such as autism, anxiety, or depression, rather than choosing one main label. These shifts make it easier for people, especially teens and adults, to qualify for an ADHD diagnosis than it was in the past. The importance of impairment. Official criteria for ADHD don't just look at symptoms, they also require proof that those symptoms are genuinely getting in the way of life. A thorough evaluation should include a detailed history, standardized questionnaires, and input from multiple settings, such as family and school for children, or work and home for adults. Here's a subtle but crucial point: almost everyone occasionally loses their keys, daydreams, or fidgets. ADHD becomes a medical issue when these traits are frequent, long-lasting, and cause problems such as repeated academic failure, job loss, or serious relationship difficulties. The tricky part is that deciding when someone has crossed this impairment line is somewhat subjective and varies across clinicians and cultures. Different countries, different pathways. How easy it is to get an ADHD diagnosis depends heavily on where you live. In some places, a wide range of professionals can diagnose ADHD, including primary care doctors who may have limited specialist training and very little time per visit. In other regions, patients are more often referred to psychiatrists or neurologists, but there may be far too few specialists to meet demand. This leads to an uncomfortable contrast. In wealthier settings, critics worry about superficial assessments and overdiagnosis, while in lower resource settings many people never get evaluated at all. Stigma, limited mental health services, and lack of awareness mean that ADHD can go unrecognized, especially in marginalized or vulnerable communities. The 3 ADHD presentations. Modern diagnostic systems describe 3 main ways ADHD can show up. One is predominantly inattentive, where people often overlook details, struggle to stay focused, misplace items, or are easily sidetracked. Another is predominantly hyperactive impulsive, where restlessness, constant movement, excessive talking, and interrupting others stand out. The third is the combined presentation, where a person shows both inattentive and hyperactive impulsive features. For any of these presentations to qualify as ADHD, the symptoms have to last for at least several months, show up in more than one setting, for example, both at home and at school, not be better explained by another condition, and cause meaningful difficulties in daily functioning. A strong genetic component. ADHD tends to run in families, and many parents only realize they likely have it themselves when their child is assessed. Studies repeatedly suggest that a large part of the risk for ADHD is inherited, with genetic factors making a major contribution. This doesn't mean that environment does not matter, or that anyone is doomed by their genes. Instead, genes create a certain vulnerability or tendency, and life experiences, supports, and demands shape how that tendency actually plays out in a person's day-to-day life. Social media and the TikTok effect. In recent years, ADHD-related content on platforms like TikTok, Instagram, and YouTube has exploded. Many people describe finally recognizing their lifelong patterns in short, relatable videos or posts, things like constantly starting new projects, zoning out in conversations, or needing intense interest to get anything done. This visibility can be empowering and can prompt people who have struggled in silence to seek professional help. But it also raises concerns. Quick self-diagnosis based on short clips can be misleading, and some online services may offer fast diagnoses with only brief questionnaires or video calls, without the depth required for a thorough evaluation. Underdiagnosed, overdiagnosed, or both. Here's another controversial twist: ADHD can be underdiagnosed and overdiagnosed at the same time, depending on who you look at. Some individuals receive labels without comprehensive assessment, while others with obvious, long-standing difficulties never come to clinical attention at all. Specialists working in the field often say the more pressing problem is the people who fall through the cracks, those who are dismissed as lazy, messy, or unmotivated instead of being offered a proper evaluation and tailored support. From this angle, improving the quality and thoroughness of assessments is more important than simply reducing the overall number of diagnoses. Gender bias and the missing girls in